Good afternoon, everyone. I am Adafshin on behalf of IGCP. I extend a very warm welcome to all our respected doctors and dietitian and participants joining us today for this digital academic session. Today's topic is extremely relevant in current clinical practice: medical nutrition therapy and lifestyle in MASLD, MASH. With the rising burden of metabolic dysfunction, associated steatotic liver disease, nutrition and lifestyle intervention are no longer supportive therapies. They are central to disease reversal, prevention of progression, and long term patient outcomes. Evidence based dietary strategies, weight management, and sustainable lifestyle changes play a pivotal role in managing MASLD and MASH. It is my privilege to introduce our speaker for today, Dr. Rita Anand Singh, ma'am. She is the senior dietitian. She is the Department of Gastroenterology, GM Surgery. Dr. Rita Anand, ma'am, brings such a rich clinical experience in managing complex gastroenterology and liver disorder patients. Her practical evidence based approach to medical nutrition therapy makes her the ideal speaker to guide us through today's topic. With great pleasure, I now invite Dr. Rita, ma'am, to share her insights with us. Ma'am, this is over to you. You can proceed with the next. Thank you.
Thank you, Ada. Thank you so very much. Good afternoon, distinguished speakers, clinical practitioners, doctors, healthcare professionals, and gastroenterologists, hepatologists. So it is pleasure to be here to discuss a very burning topic. I would say that it is raging so fast, like an epidemic or endemic. So it is pleasure to be here to talk about a condition that sits at the every corner of nutrition, metabolism, and long-term health outcomes, especially those conditions which are directly related to metabolic dysfunction associated cardiometabolic diseases like liver disease. So earlier it was known as fatty liver, but due to certain conditions and alcohol intake and the pattern of alcohol intake was may or may not be associated with these kind of patients, so the nomenclature has been changed from the fatty liver NAFLD to MASLD now. So why MASLD matters? Because it has so many dimensions of disease. It is not only about the liver disease or steatotic liver disease, which is mainly part of the liver. So the fat accumulated, if the fat is accumulated more than 5%, it is known as steatosis. So this is the prevalence. This beautiful slide shows that the prevalence all over world is so high, which is published recently in October 2025 in Clinical Journal of Hepatology. So I would love to discuss about the Indian scenario, especially South Asia scenario, as India is located in South Asian region. So 60.98, almost 60%. Now globally in within from October 2025 to now, this February 2026, it is expected that from 26.98, it is now around 68.26%. So this is raging so speedily, or the prevalence is raging so high. So being a clinical practitioner, dietitian, or hepatologist, it requires everybody's attention so that we can control the medical burden of this kind of disease. So again, the if the disease is undiagnosed, unattended, it can sorry, it can from steatosis to it can change into the metabolic associated dysfunction, hepatitis. Then, if again unattended, it can, 41% can be converted into a, can be progressed into the significant fibrosis. If again it is not controlled or untreated or undiagnosed, and because of undiagnosed, the population is just having very slow kind of progression, very less symptom, because this fibrosis as steatosis is not always having very acute kind of symptoms. So again, it is a hidden kind of medical burden or health burden. So if it is undiagnosed, it can change into advanced fibrosis. Again, if it is not well treated or undiagnosed, not treated, or even if it is treated, some of the cases becomes SCC. This again hepatocellular carcinoma has developed. So it all requires attention, medical attention, then government attention, then personal attention as well, so that the metabolic, initially the metabolic dysfunction associated obesity, insulin resistance, dyslipidemia, cardiometabolic conditions can be controlled, and so as the steatotic liver disease can be controlled. So this is the natural history of how the fatty liver became the MASLD. Here, this slide is very old slide and published again in the Clinical Hepatology in 2025 February. So, timeline for the evaluation of metabolic dysfunction associated steatotic liver disease was initially in 1836. It was known as the fatty liver. First described, the first case was diagnosed as in 1836 as fatty liver. In 1884, it becomes the patient, next patient was diagnosed with the diabetes. So again, pathologically, the insulin resistance, then hypertension, then dyslipidemia, and abnormal hip waist ratio, BMI was too high. So again, the changes of the nomenclature has become fatty liver to NAFLD, then match if alcohol was the pattern of alcohol and the amount of alcohol was associated with this kind of conditions, metabolic, cardiometabolic conditions. Now it becomes plus minus. Again, the MASLD in 2023, there was a consensus guidelines, and hepatologists, clinical gastroenterologists came across for this consensus guidelines, and it becomes from MAFLD to it became MASLD. In 2023, MASLD, metabolic dysfunction associated liver disease, was proposed as a replace for NAFLD and MAFLD to not only highlight the metabolic features but also to replace stigma with term alcohol was associated, if associated or not associated. So MASLD has came into the limelight in 2023. So again, if the previous slide was saying, if alcohol intake amount and pattern was associated with MASLD, then what? So steatotic liver disease, SLD, steatotic liver disease is the term. So MASLD, and if alcohol intake, the amount and the pattern for male and female is different, is associated with SLD, so it becomes MATLAD. So MATLD and increase in alcohol intake becomes MATLAB. This is the nomenclature. MASLD, then MATLAB, alcohol associated liver disease, ALD. Then specific liver drug injuries, monogenic diseases, and this miscellaneous, this cryptogenic and genetic conditions are also involved with the liver diseases. So again, what are the main current understanding of the progression and regression of MASLD? So fatty liver, if more than 5% of hepatocytes are full of fat or fat lipid, it can be known as SLD, metabolic steatotic liver condition. So if it is attended by the doctors or dietitian, so by counseling for the nutrition and lifestyle intervention, 15 to 30% can be reversed towards the healthy liver. If unattended, they will be become the person or patient will get the steatotic liver disease. Again, at this, even at the MASLD, cardiometabolic conditions are involved. Again, 12 to 40% cases can be reversed at the steatosis, steatotic conditions. So 12 to 14 can be reversed by the healthy lifestyle and nutrition intervention. Again, if unattended, then can steatotic hepatitis can develop. So steatosis, inflammation, ballooning, and fibrosis again cannot be reversed, but progression can be slowed by a healthy lifestyle and nutrition intervention. So you can see the arrow, blue arrow is, it means it is reversible. The condition is reversible till the till the fibrosis, ballooning, inflammation is there. But at the advanced fibrosis, this cannot be reversed. So 15 to 20% fall into the cirrhotic condition, late stage of fibrosis, which is advanced fibrosis. Then again, this condition becomes the hepatocellular carcinoma, which requires transplant. Even at the condition cirrhosis, compensated or decompensated condition needs this SCLF becomes the core cases for the liver transplant. So these condition up to 1 to 3, up to the third stage, the 40% cases can be reverted to the healthy lifestyle. So medical personnel and practicing dietitian need to be very conscious when these kind of patients come to the. They need a tailor-made regime, lifestyle, and nutrition intervention. If they have any kind of other medical like cardiometabolic condition, should be considered while treating, while this counseling for the lifestyle intervention. So cardiometabolic other condition like hypertension and this insulin resistance, then diabetes condition need to be considered for diet. Metabolic dysfunction associated fatty liver disease are again the same spectrum. So MASLD diagnostic criteria. So I won't go into this, but just briefing that if the person is having the more than 5% lipid in the liver. So with these conditions, BMI greater than 25 per kg meter square and fasting serum glucose more than the 100 mg per deciliter of blood and blood pressure more than 130 by 80 diastolic more than 85 mmHg are specific with the antihypertensive drug. The patient is maintaining this much of hypertension. So plasma triglyceride greater than 150 mg per deciliter of blood. These are the metabolic condition or cardiometabolic condition. If the person is having more than 5% fat steatosis in the liver and along with that steatosis more than 5%, BMI is greater than the normal, fasting serum glucose is greater than the normal, blood pressure is normal, greater than the normal, and plasma triglyceride more than the 150 mg per deciliter of blood, or HDL is high. So patient falls under the category of metabolic dysfunction associated liver disease. So, what is the dietary or in nutritional intervention? So, a multidisciplinary approach, integrated dietary and lifestyle modification is essential for effective metabolic dysfunction associated steatotic liver disease management. So, what guidelines says That again, I have this beautiful slide from ESLD and is practices published in Journal of Hepatology in September 2024. So, algorithm which focuses on how to manage pharmacologically and with the lifestyle and dietary intervention. So, MASLD with overweight or obesity, if the weight if a person falls in obesity, just grade 1 or just obesity grade criteria, the steatosis can be improved or can be reversed if weight person patient achieves great weight loss up to the 5% and MASLD with class 2 or class 3 obesity, the person or patient is recommended to reduce the weight up to 7 to 10% for mass and fibrosis reduction. And if the person achieves greater than 5%, the quality of this fibrosis, ballooning, and inflammation can be reduced and can be seen in histological and imagings. So MASLD with normal weight are only can achieve the normal liver or can achieve the lipid accumulated in the liver can be reduced by attaining only 3 to 5% weight. If the patient is already on normal weight, still we need to suggest and focus on the muscle weight, not only the total BMI or so. So 3 to 5% weight reduction is still required in lean mass. So prevention of MASLD and SCC, preventive obesity, healthy life, regular physical activity, just stay away from the sedentary lifestyle, and processed and packed ultra processed food should be avoided. Then smoking, quick smoking and alcohol is also suggested. What are the dietary recommendation? Recommendation to all MASLD: diet quality, Mediterranean diet, minimum processed meat, ultra processed, and food loaded with the sugars and sugary beverages are not suggested. So, what kind of physical activity? So, while suggesting diet or physical activity regime, it is always recommended and should be focused on the individual's ability to train. Just initially, we need to take the deep history of the person. If the person is already doing some activity as physical exercises, so we need to increase the time length and intensity of the exercise. So blindly, just we need not to suggest go for a walking or just do this kind and that kind of exercises. So deep history of the patient, if the person is already just focusing on the gym and type of exercises but not taking or not considering his or her diet, so we need to focus the diet and nutrition part basically. Then how to implement? So multidisciplinary care along with the physiotherapist, dietitian, clinician, or hepatologist and gastroenterologist, we need to sit across the table and discuss about the individual case so that we can deep I mean dive deeply in the case history, and understanding comes this way. Better way, we can gradually ask the patient a case to implement this and that, and then again the we should give the logical goals, not to just ask the patient to reduce weight up to the 10% or 10 kgs, or these are the goals. So realistic goals need to be discussed and implementation should be done accordingly. Again, so NAS and MAS Council, Global NAS and MAS Council, again focus the same kind of guidelines. So weight goals, again 5% of total body weight to reduce liver fat. Reduction of fat 7 to 10% improves liver inflammation. More than 10% of total body weight or fat to improve fibrosis can be improved. A reversal should be can be done if the person is obese up to the 2 to 3 class of obesity. So 10% improvement, reduction in the weight shows the reduction in the fibrosis as well. So again, the because of the physical, I already mentioned here. So physical activity or dietary intervention needs a dive deep dive into the patient's, a person's history. If we blindly suggest that this much weight can reduce the lipid into the liver, or fibrosis or inflammation can be reduced. So patient may not be many a times is not able to apply that kind of diet, maybe because of some reasons age related, or the patient is not trained, or the willpower is not so much is there. So we can suggest that patient is can be considered for the bariatric surgery. But again, I would say this is part of lifestyle and nutrition intervention. So being a dietitian, I must again focus the tailor-made and personalized touch needs. Realistic goals should be given to the patient so that we can achieve gradual, but results can be achieved. So lifestyle is not only about the nutrition and exercise, it is also about the quality of sleep, stress management, avoiding alcohol, following circadian rhythm and biological clocks as well. So here some guidelines suggest that sleep quality should be considered, not the sleep hours. So it is not always 7 to 8 or 8 to 9 hours is recommended. If the person is sleeping, sound sleep is there, the hormones which induce the sleep and quality of sleep is there up to the mark. So 6 to 7 hours sleep is adequate sleep is enough to manage the that uh, stress, or manage the metabolic conditions, or stress can be reduced. So healthy diet is already discussed, by cutting to 500 to 1000 calories per day can be recommended for an obese person who comes in 2 to 3 grade of obesity. But blindly we cannot suggest this much of calorie. As I every time I mention that personalized, the person who is already eating ultra processed and processed food, having lots of carbonated drinks, and addicted to the sugary and products, then cannot be asked to take salad, cannot be asked suddenly to change the diet and lifestyle. So we need to train the person or patient to take, set the realistic goal, and train the gut to reduce the processed food, reduce the portion size, then can be the target can be achieved. So guidelines is 500 to 1000 calories, cutting by cutting 500 to 1000 calories per day can be recommended. So this is recommended because the hepatic liver fat can be reduced, and mass and fibrosis can be reduced. Then comes coffee. So drinking 3 cups of coffee or more per day can reduce the risk of MASLD or liver fibrosis. But again, blindly do not recommend the coffee, as coffee aggravate hypertension. If the person is already having, along with the hepatic steatosis, cardiometabolic conditions are there, like hypertension, insulin resistance, then dyslipidemia is there. So patient may again can fall into the accelerated hypertension, or blood pressure can raise. Coffee can raise the blood pressure as well, and then this headache kind of conditions are can be aggravated. So mindfully decide, take the history, and then decide how much dark coffee or black coffee can be suggested in the nutrition plan. So smoking and alcohol is almost should be stopped. So here are evidence-based dietary approaches of MASLD management, different types of diets and role in MASLD. Here the most studied diet is Mediterranean diet. So this diet is the most studied for MASLD management. This is basically not I would say that not suitable for Indian, because Indian diet pattern is entirely different from Mediterranean, but some of the components can be included to our Indian diet that I'll discuss later on. Mediterranean diet, low carbohydrate diet, or ketogenic diet. Then ketogenic diet is almost very much in trend now. So ketogenic diet has again many patterns, like the 20-30 3 to 2 ratio. 3 is fat, or 2 is carbohydrate. The 70-30s are 80-30 or 80-20, sorry, 80-20 pattern is there in ketogenic diet, while deciding the carbs percentage and fat percentage. Then high fiber diet, other dietary pattern. Then role of specific nutrients and bioactive compounds for management of MASLD, like vitamin D has a very uh, promising role, choline, omega-3, and then antioxidants, selenium, zinc, phytochemicals, flavonoids, and resveratrol is also having a very promising role and very much researched in relation to MASLD. Here you can see this beautiful plate of Mediterranean diet, which includes almost the more of the portion of the plate is filled with green vegetable, multicolor fruits, and berries are there. So fruits and vegetable, fresh beans, green beans, then fruits are major part of this kind of diet. And then lean protein, by which comes from the low dairy fat and seeds and nuts. Then lean chicken is there and egg is there. So protein, quality protein is also has been considered for the muscle mass preservation. And whole grains which are not actually processed or refined. The controlled portion is mentioned here. The legumes are also part of this diet, and again wine is here in Mediterranean diet. That's why I already mentioned that this is not, because our population is not so sorry to say ki, compliance for the, if I say you can take this much of uh, wine or alcohol, they will not be adhere to the portion size. They may fall into the bigger size a portion of the. They may change their pattern. If doctor or dietitian say you can take this much of wine, this much of alcohol, this much of alcohol percentage can be taken. So the population which I deal, which you deal, is not that much compliance to the prescription, nutrition prescription or medical prescription. So better ask them not to take wine and alcohol even as per the guidelines. So Mediterranean diet, the major component are MUFA, PUFA, omega-3, fiber, polyphenols. So MUFA is responsible for hepatic metabolism by reducing de novo lipogenesis and increase fatty acid oxidation. And then PUFA is also responsible for reducing the lipid accumulated in the liver and increase the lipogenesis to use the fat which is already accumulated in the liver for the energy purposes. And this PUFA reduces the inflammation as well. Omega-3 fatty acid has a very promising and most studied role in liver health. So what does it do? Fatty liver polyphenols, anti-inflammatory effects, reducing hepatic inflammation and fibrosis. What fiber does do, then reduce fat accumulation, improve insulin sensitivity, lowers circulating level of inflammatory markers. Polyphenols again and MUFA, they works along with MUFA combined way, positively modulate gut microbiota. So gut liver axis is there. So if we increase the polyphenols in the diet, fiber in the diet, that improves the intake or uptake of this that improves the quality of gut microbiota and directly reduces good quality microbiota is responsible for reducing the inflammation and hepatic lipogenesis that increases the hepatic lipogenesis and reduces the inflammation. So here are the good references which are available for the reference. Then, what are the big, yeah, major component of the Mediterranean diet is extra virgin olive oil. The Mediterranean diet major component is green leafy vegetable, green beans, fava beans, then fresh fruits and whole grains. Along with all these, the meat, fish, and salmon is also a good source of this anti-inflammatory components. And then again, extra hepatic virgin oil also helps in hepatic steatosis, available as antioxidants and anti-inflammatory effects, improves liver biomarkers ALT, AST, and GGT, improves of lipid and glycemic control as well. Body weight and BMI can be controlled by increasing the metabolic rate. So the next type of diet, which is also helpful in improving the MASLD condition, low carbohydrate and ketogenic diet. Approach to MASLD due to their effect on insulin resistance and hepatic fat inflammation. Again, insulin resistance and type 2 diabetes is also majorly associated with the MASLD. So, by reducing the insulin resistance and hepatic fat metabolism, the lipogenesis can be generated to use the accumulated lipid in the liver for the energy purpose, and the rest can this achievement can reduce the liver fat, and then fibrosis can be reduced. So, what are the major components of low carbohydrate? Maximum the diet consists of green leafy vegetables, seasonal vegetable, capsicum, pumpkin, bottle gourd, and other green leafy vegetables. Then lean chicken and poultry and egg for the quality of protein, low sugars, and low GI fruits, the glycemic index, the fruit which has the low glycemic index are fruits are the component are part of this kind of diet: citrus, lemon, berries, oranges. Then low fat nuts in a controlled portions are allowed for PUFA, MUFA, and omega-3 fatty acids availability. Low-fat dairy products are also component of on this kind of diet. Grains and cereal, whole grain cereals and pulses with chilka are also the part of this kind of diet to generate the low glycemic index and low glycemic load for the diet, and this increases the delayed gastric emptying so that the person feels hungry after a long time. So these are the examples of high fiber diet to improve insulin sensitivity and reduce the inflammation. Or green leafy vegetables, corns, this broccoli, oats, and oats products are a good source of soluble and insoluble fibers. Again, sprouts has many good kind of antioxidants. Vitamin E is also very helpful in reducing the inflammation of the liver and the dose on this already medical prescription or practitioners suggest that 800 IU vitamin E for 3 to 1 year for there are many RCTs or meta-analysis that shows that vitamin E has a very good effect on the liver health. So this sprouts and celery and this tomato, berries, actually Indian does not have that kind of uh, dietary vitamin E availability. So we need to focus on vitamin E component for good liver health, and variety of foods need to be incorporated consciously. So again, emerging strategies in medical nutrition therapy is gut microbiota modulation for liver gut health. Liver gut access is the concept where we can focus on the this reducing inflammation, improve gut barrier function, lower hepatic fat accumulation. So, as the MASLD can be managed or improved at ballooning inflammatory state or fibrosis before it is worsening or before it is going to the uh, advanced fibrosis. Precision nutrition focuses on omics like genetics, metagenetics, metagenomics, and metabolomics. So this is the newer concept, and it focuses on the metabolic studies which are related to DNA kind of things, and see this the prevalence of this kind of the data or studies or researches not so it requires lots of studies or study or data or, to be come into the existence for better understanding of precision nutrition. But yes, personalized nutrition based on phenotype data like age, gender, activity, and dietary habits according to their regions and work and lifestyle is also need to be considered for personalized nutrition works, and as wonder for any kind of metabolic dysfunction associated or cardiometabolic conditions. So, one while treating or while managing the MASLD by the dietitian or clinician, the personalized nutrition is the key to uh, uh, manage this condition. So again, these kind of there are n number of diet which has been studied for in relation to MASLD or cardiometabolic conditions. So role of specific nutrients and bioactive compounds. So here are the examples. The role of the omega-3 PUFA and MUFA reducing the inflammation, reducing the oxidative load in the liver or in the body. Polyphenols are present in the this kind of dietary fibers and oil, which is responsible for the gut health also. So here are the good sources of this omega-3. So red rajma, I'm sorry. Red rajma, walnut, chickpea, bean, soya bean, and fish are the good sources of omega-3. PUFA, again, walnut, flaxseed, avocado, peanuts, and sunflower and sunflowers. This flower part also consists of the good kind of omega polyunsaturated fatty acids. So MUFA, good quality of nuts can be recommended or can be taken for the uh, quality fat, avocado, almond, then the sunflower oil, and mustard oil is a good source for Indian to achieve the combination and good quality fat along with the PUFA and MUFA. So it all requires to focus on the total calorie and quality of protein which is recommended this kind of patient. So while recommending for any kind of PUFA or MUFA, it is all source of fat and energy. So total calories should not go beyond the recommendation to achieve the goal, realistic goal of reducing the body weight as well as lipogenesis. So this is the a chart which can be patient can be encouraged that when they come to the next follow up to the dietitian or their clinician consultant, they can reward this way if they are doing good in means of activity and quality of diet. They can they can have a chart like daily assessment. They can do their own daily assessment. Then they can present this diet chart or this kind of emojis to the consultant for their uh, progress, as a progress. So what kind of exercises are can be advised or can be suggested to the MASLD patient with cardiometabolic dysfunctions? So, aerobic exercises for 150 to 300 minutes per week. If the person is doing the moderate activity, or just intensity is very high, so 115 is 15 minutes per week is okay. Moderate to intense exercises are 150 minutes per week is okay. If the person is doing very vigorous intensity, but under the guidance, but under the this supervision, so 75 to 150 minutes per week vigorous exercises, vigorous intensity exercises is quite must to reduce the accumulated liver fat. Then resistance exercise, aerobic is the other set of exercises, and then resistant exercises along with the resistant exercises. Then if the person is sarcopenic obesity is there, so the patient need to be evaluated for strength and for the physical conditions. Then only resistance exercises and set of strengthening exercises can be gradually incorporated in their nutritional lifestyle interventional related prescription. Like 2 to 3 sessions per week are quite enough. Initially, patient need to be educate for these kind of what are the exercises which comes under aerobic and resistance exercises. So need to be educate about them with the physiotherapist, with the qualified person whosoever can take care if anything is uneasy or uncomfortable to the patient. Initially can report to the person, then to the consultant also. So aerobic resistant exercises, this much time is enough. Initially, gradually can be increase. The initially the time can be restricted or slow down can be asked. Just they need to ask. Just warm up themselves. Then the intensity can be increased. Then last 15 minutes can be the slow down or cool down kind of exercises need to be the part of the exercise regime. Then the intensity and time need can be increased as per the goals and physical performance. Frequency and intensity, then sedentary behavior, reduce prolonged sitting, take frequent movement breaks while sitting or doing their desk job, and doing the all the time just writing the prescription or doing work on the laptop. Just stretching movement, just walk around the in the room only helps a lot. Then outcome, reduce liver fat and improves insulin sensitivity even without weight loss. So achieving insulin sensitivity itself can reduce the liver lipid, and then the intensity and type can be increased gradually. So it it was about exercises for MASLD with the references and with the guidelines. So there are a number of RCTs, meta analysis that proves that exercise, these kind of exercises, helps in reducing the liver fat, and cardiometabolic conditions can be reduced or can be improved up to the normal condition. So here there is another kind of exercise which is known as non NEAT is non NEAT, non exercise activity. N is stands for non, E stands for exercise, A activity, then thermogenesis, T stands for thermogenesis. This means even if the person is not doing anything, then the calories I mean, the exercise pattern is not regimed, or that exercise pattern is not adopted as exercises, like doing the daily task, cooking, or just going for the grocery, or going talking while on walking while the talking on phone, or taking a glass of water by herself or himself is a kind of need. Non-exercise activity thermogenesis, which is the major part of the calorie burn. So we can see that at 0 to 1 scale, the exercise part is this upper part is exercise, which we hardly one or we do 1.5 hour intentionally. That burns hardly 10 to 12%, or hardly if the person is doing gym and rigorous or in high intensity exercises, that can expend only 15 to maximum 20% of the total calorie per day. Then thermic effect of meals. The food which human eats uh, gets metabolized, then break down. It requires food molecules to be break in small molecules. Then absorption is there, digestion absorption is there, then activity absorption, and then the itself it required, then metabolic functions require multiple biochemical functions inside the body. That is known as thermic effect of meals, which is directly related to digestion, absorption, and metabolism. That requires 10 to 12% of the total calorie, or we can say up to 8% calories we burn by thermic effect of food. Resting metabolic, the body, when we do not human do not do any activity intentionally, like while sleeping, and the resting energy metabolic rate is energy the body expend while at the rest to maintain basic physiological functions like circulation. The circulatory system in their body has almost 9 to 11 function inside the body, like neural cardiovascular system, then neurological system, then secretory, excretory, and many systems are there. Those systems knowingly unknowingly work 724. So the energy expenditure for the resting metabolic rate is almost 70%, but need takes almost half of the portion, even if we knowingly do not plan or do not follow a exercise regime. So this says the being active while being at office or at home, we can burn lots of calories. So consider need. We do not follow a sedentary lifestyle. Do not stay in your bed. Do not stay in chair for a long time. Just go around in the house. Go around in the office or room, just to improve your thermic effect of non-exercise calorie burn. So what is the importance of this kind of neat non-exercise activity thermogenesis? As I told, that it burns almost 15 to 18 to 15 to 18% of total calorie unknowingly. So it has a very good impact on health, as high level of meat can account for up to 2000 calories of daily expenditure. It is associated with better metabolic health, reduced cardiovascular risk, and better weight control contribution to daily life. Meat often accounts for a much larger portion of total energy expenditure than structured, which really we do for 60 minutes or 90 minutes. So need takes lot of calorie to burn than the structured regime. So international exercise, this is more important than the structured regime or exercises. So what is the take home message? So weight management in MASLD is very important, a central role. While prescribing, we need to focus, we need to tell the patient, we need to counsel the patient to reduce the weight up to his physical and mental, and we need to prepare the patient to reduce weight so that the liver steatotic liver can be improved and steatosis can be reversed. Then calorie, how to control weight management, calorie control over fat diets. Uh, as I already mentioned that there are several diet which has been studied in management of MASLD, Mediterranean low carbs, time restricted, time intermittent fasting was there. Intermittent fasting is there. Time restricted eating is there. High fiber, low carb diet, and other dietary patterns are there. So I would request to stick the realistic goals and do not stay on the fat diet, which cannot be sustainable, which can the adherence is the main problem with these kind of diet. So calorie restriction, then uh, processed that ultra processed food need to be cut down, and portion size can need to be controlled for a period of time. Then weight management, a weight reduction can be achieved. So do not stick on or follow any fat diet, just make it lifestyle, part of life, to restrict the calorie. Do not take ultra processed or processed food, just reward yourself occasionally with these processed or ultra processed or outside eating can be considered as a reward if the person is considering throughout the week, throughout the month. Improve carbohydrate quality as limit refined carbohydrates, white rice, maida, pasta, sugary beverages. Prefer low glycemic index carbs like whole grains with chilka, and with the millets can be included in the diet which has low glycemic index. Legume with chilka, vegetable, green leafy vegetables, and variety of colors and fruit need to be incorporated in diet. So those vegetables, fruits, we do not recommend the exotic fruits and vegetable or any exotic food and feeds. Just take and choose the local and seasonal fruits and vegetable which are available in the region. Then restrict added sugar and fructose, which are highly having the very high glycemic index and glycemic load, which is almost responsible for this lipid in the liver accumulation. Choose healthy fats. Choose healthy fat. Do not recycle the fat which has been used in the home as well as in the market. Just try to avoid the palm oil, everywhere in the market, in the restaurants it is the palm oil. So better do not go so frequently for the outside eating. Just eat at home, eat locally and seasonal. Adequate high quality protein while restricting the carbohydrate and fats. The high quality protein is very much should be taken into consideration to maintain the muscle mass, lean mass, for better strength and better quality of protein. The quality protein should be taken into consideration. Increase dietary fiber to improve the insulin resistance and gut liver access and health. So dietary fiber plays a very good role in improving the gut microbiota. Limit or restrict the alcohol. So I will not talk over the alcohol intake. Just stop or counsel the person for stopping the alcohol intake. Meal timing and portion control. It does not matter what you eat or I eat. It matters how much and when you eat. So avoid the late night eating and frequent snacking. Encourage regular meals with mindful portion sizes. It does not matter how what you eat. It matters how much you eat. So mindful portion control is the main key point. Physical activity is non-negotiable. And many a times when patients comes in follow up to me, they used to ask, "This is very cold outside, so I'm not going for walk or exercise. I'm not going to the gym because I mean, winter is there, so and the days are very short, and the household chores and office is already bhagam bhag is there, so I'm not getting time." So just counsel the way the patient or person have that much kind of will, may generate that kind of will to reduce the weight and to go for the physical activity, which can be non-negotiable over the season, over the time, over the health, over anything. Manage associated metabolic condition like optimize control of diabetes, dyslipidemia, hypertension through diet and lifestyle. Supplemented supplement used judiciously, just like I already said that vitamin E has a very good role in liver health. So without having the blood reports or just lipid this serum levels of any of the vitamin or any of the supplementation is not suggested here until unless the patient or person is not having the report, and that too in lower level, then only consult or multidisciplinary approach need to be incorporated, need to be just I would say that need to be discussed among the clinician, then the dietitian need to be there to discuss these kind of doses. Long term lifestyle, not short term. These approaches should be dietary, nutritional management, exercise regime, stress management, good quality sleep, and yoga, meditation should be a part of life, not for the treatment of MASLD. Yes, just if MASLD happens, then MASLD during the management, and then once the person has achieved the normal liver, the dietary and behavioral changes, those who supported in the management, should be continued. It should be part of life. Regular monitoring and follow-ups are suggested for periodic assessment of weight, hip circumference, liver enzymes, and metabolic markers is essential. Once the person has achieved MASLD, cardiometabolic, this conditions are not there, the liver fat is normal now. So still regular follow-ups to the physician, to the dietitian is recommended here. Again, a personalized approach a tailor-made approach is required for each and every individual. The every size does not fit to all should be the principle for managing any kind of disease, even if it is about the MASLD or weight management or insulin resistance is there. So everyone is individual, uniquely designed by the God. So personalized approach and the precision nutrition should be implemented. Thank you for patient listening.
Mm,
Hello, am I audible?
yes, yes, ma'am. Thank you for this wonderful presentation, ma'am. Shall I take question one by one from audience, ma'am?
Yes,
Okay,
sure.
sure, ma'am. So the first question we received, ma'am, what are the most
Can you
important?
hide? Can you stop sharing my slide from your side
Yeah, yeah,
because
yeah. It is done, ma'am. It is done.
still
Now
I'm not.
can you
I
see
don't
the
see the
screen?
US screen. Question is there. I
Yeah, yeah,
don't
ma'am.
see.
I'm seeing for you, ma'am. I'm seeing for you on behalf. I will take.
Okay, just a few
Yes.
seconds.
So the first question is, ma'am, what are the most important dietary changes that have shown consistent benefit in reversing early MASLD?
The all the guidelines word wise has suggested that a small reduction in the weight, even if it is a small reduction, the person is able to reduce up to 3% of the ideal body weight, of the present body weight, that can reverse the inflammation and liver fat, liver lipids up to the normal. So first line treatment is, even if the person is lean, the person is on his or her ideal body weight, even then if this steatosis is found in the imaging or in the histopathology, the first line treatment is weight reduction. So it should be in under the guidance of a trained dietitian, and under the it should be a multidisciplinary approach. So the weight reduction by controlling the ultra processed food, and then sugary products and quality of carbohydrate, type of carbohydrate need to be monitored and need to be restricted as per the total calorie recommendation. So weight reduction and quality of carbohydrate and type of carbohydrate helps in reducing the steatosis.
Okay. Thank you so much for this brief answer, ma'am. So the next question is, in which patients with MASH, how should calorie restriction and macronutrient composition be balanced to ensure both liver improvement?
Can you repeat the question, please?
Sure, ma'am. So the question is, in which patients with MASH, how should
Hmm.
calorie restriction and macronutrient composition be balanced to ensure liver improvement?
Yes. So the basic balanced diet concept is 60% carbs, 15%, 10 to 15% protein, and 20 to 25% fat. But because the mass is directly associated with the cardiometabolic dysfunction, that is the higher hip waist ratio, insulin resistance, high this lipid profile, dyslipidemia is there. So we need to just change this scenario, like carbohydrate, type of carbohydrate and quality of carbohydrate should be changed, should be switched from the simple or processed to the complex kind of carbohydrate that should be in composition of soluble and insoluble fibers. Then the protein, which was earlier suggested 10 to 15%, can be more than 15 to 20%. That is little hard to achieve in Indian scenario. But if the person is vegan or over vegan, so over lacto vegan, then can be achieved by allowing the person the fat free dairy. Along with that, the quality of protein can be mentioned by allowing the egg whites, and then this beans, chickpeas, then pulses, and rajma beans can be allowed for the quality of protein. Next is fat. The quality of fat need to be designed or tailor made, which need to be focused on PUFA and MUFA basis. But the total calorie which has been recommended to the patient should not exceed, because we are focusing here to take or increase the intake of PUFA and MUFA, that are the sources of fat. So total calories should be as per the guidelines or as per the recommendation. So 60%, less than 60% carbs, then 20% fat, 15 to 20% protein need to be to maintain the this lean mass or protein mass, muscle mass. So 15 to 20% protein should be allowed to the patient to achieve the total micronutrient.
Okay. Thank you so much for this brief answer, ma'am. So the next question is, are there specific food pattern or dietary approaches that you routinely recommend for these patients?
Sorry, what?
Ma'am, are there specific food patterns or dietary approaches that you
Yes.
routinely recommend for these patients?
Yes, very recently there is a paper published in from my department with the from the Department of Hepatology, SGPGI. So time restricted window and this intermittent fasting. It's not actually intermittent fasting, but it's a time restricted pattern. So where the this lipogenesis and liver lipid has been decreasing trend has been seen, then the the this insulin resistance and diabetes control, the person, those who were on metformin or so, has been came to the only dietary and lifestyle regime. So, time restricted and the total calorie control portion, total calorie control is the regime that can be followed for reversing the MASLD, are very helpful these days. So, time restricted is we need to allow the patient to eat in the 8 hour frame, like from morning till early evening. The person can, after that they are supposed to not take any of the thing. The adherence is little bit difficult after 6 month or 1 year follow up. There the person is not able to adhere for that long time, but within the 6 year we have seen the patient are coming with the normal fibro scan, and then for with the normal histopathology. So time restricted and calorie control patterns are very helpful in managing the MASLD or cardiovascular diseases.
Okay. Thank you so much, ma'am, for such an insightful and practical session, ma'am. Your clearer guidance on nutrition planning and lifestyle modification has added immense value to our clinical understanding, ma'am. So, with all your permission, ma'am, shall I conclude this session?
Sure, sure, sure.
Okay. On behalf of IGCP, ma'am, I thanks to all our participants for joining us today and being in active part of this learning experience. Wishing everyone good health and a wonderful evening ahead, ma'am. Thank you and take care, ma'am.
Thank you. Thank you. Have a great day. Thank you for giving this opportunity as